Thank you all for coming out. My name is Dr. Bill Hofmann. I'm one of the ear, nose, and throat guys here at Fort. And I'm going to talk a little bit about some of the cases and causes of sudden hearing loss that I've seen in practice. That's the main objective of the talk, but got a couple others as well. Since I'm relatively new, I thought this is a good way to introduce myself to the community, let you all know who I am, and also take a little time to learn about the ear. It's a fascinating structure. In all honesty, it's one of the main reasons I went into ENT. So to me, the ear is an awful lot of fun. So I hope I can convey some of that to y'all. All right. I was born and raised here in the Midwest, raised in Cincinnati, Ohio. I've spent my entire time in the Midwest, with the exception of 4 years down south, where I got an appreciation for good barbecue, reasonable manners, and college basketball. Then I came right back to the Midwest and have not left. Did my medical training at University of Cincinnati, and then did my ear, nose, and throat training at Indiana University. I came up here to Fort in 2009 after spending about 6 years outside Chicago. I do not miss the city. I do like to visit it, but they can keep their 10.5% tax rate downtown, and I'll just stay up here. It's much more fun. We live out in Whitewater. I got a wife and a 9-year-old son. He's at Lakeview School, go Lizards, and we absolutely love it. Would not leave if you paid me. Now, like I said, hearing's always been kind of interesting to me because I had problems as a kid. You know, I was the typical kid that had ear infection after infection, had my tonsils and adenoids taken out, had one set of tubes, but I didn't clear that stuff up until I was probably 16. So I lived with hearing loss for part of my life, and it was not a lot of fun. The other reason I kind of went into ENT is because I had a good example. My father was an ear, nose, and throat physician, and he kind of showed me the way to go. I saw what he did. He had just a really broad-based practice. He saw kids, he saw adults, he did a little bit of everything, and it was absolutely fascinating. So it's kind of a no-brainer. Started off in ENT, and I love what I do. Now, I'm going to talk just a little bit about hearing, and it's just in general. You know, and this comes from an ear doctor's standpoint. My feeling is that people kind of take their hearing for granted a little bit. You know, we're primarily visual creatures. We live in the world. We got to see what we're doing. So everybody worries about losing their sight. That's the biggest thing. That if you talk to somebody, if they had to lose one sense, almost all of them say, I don't know what I'd do if I lost my sight. So hearing sometimes is viewed as a little bit less important than vision. And I see that a lot. I mean, I drive around, I see people in the fields. You know, they're working outside with no hearing protection. They go hunting. They don't have plugs. They're running their tractors and lawnmowers without muffs. So they don't think about it. They all got safety glasses on. They're taking care of the eyes, but kind of forgetting about the ears. Now, in my book, hearing's a little bit like the soundtrack of life. You know, something I just made up, and somebody will probably copy it and get failed miserably for it, but that's okay. You know, hearing gives a context to the world around us. Without hearing, it's kind of like looking at a silent movie without the piano. There's no emotion. There's no interest. And I got to tell you, when somebody loses their hearing suddenly, and I've been doing this for a little while, they're some of the most frightened people that come into my office. They're scared to death. They're more scared than cancer patients because they can't explain it. I heard fine, doc, and now I can't hear out of this ear. What happened? Very frightened people. So it's important to talk about it a little bit. Let's go on. We'll talk a little bit about the ear. Got to give you a little bit of anatomy. That's part of the deal with the medical talk. And start off by saying the ear, you can kind of put it into 3 separate parts. Okay? Some people would go farther than that, but for the basics, 3 separate areas. Start off with the ear canal, the outer ear, got the middle ear space here, and then the inner ear. Now, a problem in any one of those areas will lead to some form of hearing loss. Okay? And this varies from where the loss occurs. Some pretty important structures are located close to the ear, such as your carotid artery and jugular vein, the big vessels in your neck. So when people tell me, geez, I hear my pulse in my ear, I'm not exactly surprised because that sucker is right next to the organ of hearing here. It's right up close to this. Jugular vein goes behind the ear. The nerve that runs your face, allows you to smile, blink, do all that good stuff, runs right through the ear. So a lot of stuff happening in a very small space. Just to kind of give you an idea of how important the ear is to us evolutionarily, all right? Some of the main structures of the ear, the most important, are buried in some of the hardest bone in your body, right here. Makes good sense too, because when we were running around on all fours chasing dinner, if we didn't have good balance and couldn't hear our prey, we didn't eat. And if we didn't eat, we didn't have kids. So kind of important to keep that thing protected. So we'll start off with the outer ear. Basically, three separate parts to it. You got the outer ear here, or the auricle, the ear canal, and the eardrum. Okay? The ear canal itself is a two-part structure. It's partly flexible because the outer part is cartilage, and the inner part is solid bone. Ear canal makes wax. Everybody knows that. But the only place that wax is really generated is in this outer part of the ear. And wax moves out of the ear naturally as we chew and talk. So it's not really necessary to try to clean the ear. It's a relatively self-cleaning mechanism. We'll go into the middle ear. People always wonder, why do we have this? It's a real small area, actually. This little air-filled space between the eardrum and the inner ear. And its main purpose is to take sound waves from the air and conduct them through this little chain of bones to the inner ear. Those three bones are probably, well, no, not probably, they are. They're the smallest and lightest bones in the body. In fact, if I took all of them out of your ear, I could probably put all of them on my pinky finger, the fingernail, not the pad, just this little area here. When we work on these in the operating room, got to use a microscope under high power to really see what we're doing. They're relatively delicate, but surprisingly, kind of hard to take apart. There's some strength there. People often ask, why do we have this? Well, main reason is we live in an air-filled environment, but the inner ear is a fluid-filled environment. Okay? Now, anybody who's been in a swimming pool for a while knows you can hear really well in a swimming pool. Sound goes an awful long way, but it doesn't exactly sound like anything you can understand. Sort of like Charlie Brown's teacher, wah, 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 you know? So what this thing does is basically act like an impedance matching mechanism. It takes those sound waves from an air environment from a very large area, this eardrum, and concentrates it down to a real small area here. And that sets up a wave in that fluid that allows us to hear. Now we start talking about some hearing loss here, because those first two areas, there's a problem there, constitutes what's called a conductive hearing loss. Basically, all that means is you have a hard time getting sound from the environment to your inner ear. There's something blocking it off. The nice thing about a conductive hearing loss is that generally can be corrected. Whether it's just in the office or with surgery, it can be corrected with good results for the most part. Okay? Now we're going to get into the inner ear. A little bit different ball game here, because this thing is composed of two main structures. Out here, these ring areas, this is the balance portion of the ear. We're not really going to talk about that tonight. That's a whole other subject, and that can be down the pike. Right here, though, is the organ of hearing itself, called the cochlea. And that's really where we're going to talk about today. The cochlea is basically, if you stretch it out, it's just a relatively short tube. But when you look at it in cross-section, it looks exactly like a snail shell. And it's basically this membranous structure embedded in hard bone surrounding the nerve that goes from your ear to your brain, called the auditory nerve. Now, if you take a look at that, if you cut it open, it has three basic sections to it. This top section here communicates to those ossicles, okay? And the pressure wave that they generate comes down this tube. Since this is all fluid-filled, that pressure wave can be transmitted all the way across these membranes. Now, at one point in time, that sound wave is going to make this other membrane here bend at its maximum point. That's what makes sound fire, okay? So you got a receptor sitting right here that gets affected by that sound wave and fires a signal from your ear to your brain that your brain starts to interpret as sound. If you look at that thing real closely under an electron microscope, it's actually it's a beautiful structure, you know? And you see these two sets of cells, okay? There are two kinds of receptors in the inner ear. You got the inner hair cells and these things called the outer hair cells. Now, the inner hair cell is basically just a single line of receptors. These are the main receptors that code sound. So if there's a part of your ear that says this is high C, that's where you're going to find it, okay? The outer hair cells, a whole lot more of those. They basically outnumber the inner cells by about 3 to 1, okay? So a lot more of these things. And it's thought that these act like a tuning mechanism to your ear, all right? So sound, you hear it here, but these kind of affect the way your brain hears those sounds. So you need both of them to really hear effectively. When you have damage to these cells, Then you get what's called a sensorineural hearing loss, an inner ear neural hearing loss. And they seem to affect these outer hair cells first, and then later on, the inner hair cells. So what does that mean to you? Well, when you have outer hair cell damage, it becomes harder to hear in crowds or in a noisy environment. It gets harder to distinguish certain words, bat and cat. Which one is it? You can't really tell. The more damage occurs, the harder it is to sort of make those discriminations. What causes this kind of damage? Things like loud, repetitive noise. Lawnmowers, chainsaws, log splitters, all the good stuff we have up here. iPods, loud radios, you name it. Anything that's loud and repetitive can cause damage over time to these structures. Now, so the first ones that go are these outer hair cells, all right? Nice thing about the ear is you can still help people hear with a hearing aid, all right? At least until the damage starts to extend to these inner hair cells. Once that happens, it's game over. And you really can't hear much of anything at that point. All right, now we're going to get into the meat of the talk. We got rid of the anatomy. The boring stuff's out of the way. Now we start to have a little bit of fun here. So what does sudden hearing loss mean? Well, formal definition says you get a loss of 30 decibels across 3 discrete frequencies in the ear. Great. So what does that really mean? In real world terms, it means somebody goes to bed with a normal hearing, then wakes up they can't hear, or they've had a decrease in hearing in one ear. That loss can be, you notice it, but you can still hear out of the ear, all the way up to the point where you can't hear anything. All right, and that's when people start to come into a doctor's office scared to death. So the next question is, what's a decibel? I've been studying this stuff for, I don't know how long now. I've kind of forgotten, which is a bad thought. And so I know the technical definition of decibel, but I'll be dipped if I can really explain it well. That's why I have audiologists. They know that stuff inside and out. But basically, decibel is a level of sound intensity. So how much, how much is something like a whisper? Whisper goes about 30 decibels, all right? So for somebody to have a sudden hearing loss, basically it means that they can't hear a whisper in their ear when they couldn't before. Doesn't sound like much, but that's a fair hearing loss. Things like walking in the countryside, background noise, 20 decibels. Yelling gets up to about 90 decibels, all right? You get up to airplane taking off, 140 decibels. Rock music, 120 decibels, all right? So higher the decibel count, more intense the sound. Ultimately, it can get bad enough to cause pain if you don't have hearing protection. So let's start off with first patient. Very nice lady. 56-year-old, woke up, all of a sudden can't hear so well out of her right ear. So she comes into the office, start talking to her. She doesn't really have a history of ear problems. Had some infections maybe, but nothing regular. She stated that her hearing in that ear was a little funny for a few weeks before it just kind of went out. Things were sounding okay, but they sounded just a little off. Wasn't causing her problems with the conversation. She could still talk on the phone, but just not quite right. She would notice that if she went into the shower and she's washing her hearing would suddenly go down real quick, and then it'd pop, and her hearing would come back some. So she thought that might be important. And then started doing that, and she was kind of getting worried about things. She did the first thing that Mom taught her to do. She figured she's going to clean the wax out of her ear. So she grabbed that Q-tip, put it into her ear, and all of a sudden her problem got worse. The hearing went down even more, and her ear started to hurt. She's thinking, well, that can't be normal. So, what is a Q-tip? If you blow up a Q-tip, it looks like this thing. It's a cannon rammer, okay? Everybody knows that the cannon rammer, it's designed to push stuff into the cannon, all right? You might take out a little bit of black powder, all right, maybe a little bit of debris, but it's leaving the vast majority of that garbage down the tube of the cannon barrel. Q-tip's the same thing, all right? It doesn't really take anything out of your ear. It gets a little discolored on the end, and you think, geez, I did something, but what it's really doing is pushing that wax farther down. And what she had is a wax impaction. Very simple cause of hearing loss. Also, thankfully, something very easy to treat. Nice thing is, though, it's generally preventable, because like I said, ears are self-cleaning mechanisms for the most part. If you leave them alone, they'll do their own thing. That changes a little bit as people age, in certain medical conditions where the bone gets thicker and that ear canal gets smaller. But for the most part, if you leave them alone, they'll do the job for you. Basic signs of wax impaction are just what we talked about. Hearing sounds funny. It's not gone, but it sounds weird, just not normal. It gets worse if you pour water into the ear. All of a sudden it pops and the hearing improves. Treatment is real simple. You just take the wax out. Now, may not be all that easy sometimes. I mean, I've taken plugs out of the ear that follow the whole darn ear canal, and it can hurt some, especially if there's an infection going on. But once that wax is out, hearing generally goes back to normal. So that's a good sign. I'd love to see that when somebody comes in, because those people are awful grateful. They're scared to death, and you tell them something simple, end of story, they love it. People ask me about this every now and then. Home cleaning kits. You see them in the drugstore, marketed by Murine. You put the drops into the ear, flush them out with a bulb syringe, everything's better. Problem with that, though, the drops are great at softening the wax. They do a great job with that. But trying to flush that stuff out of your ear with one of those bulb syringes is really an exercise in futility. It's just not going to get much out. There's just not enough pressure in that syringe. So when somebody has a problem with their ears, or they tend to collect wax, for example, I'll tell them the best thing to do is use the drops, okay? They'll soften the wax. Use those for a couple days, come in and see me, I'll clean it out for you, and it'll make my job a whole lot easier, okay? Now we'll go on to patient number 2. I will tell you that I don't see a lot of this up here, fortunately, okay? I had to go all the way back to Indianapolis for something like this, all right? I'll tell you a little bit about Indianapolis, just as a sideline. It's not a whole lot different in some ways than Wisconsin. There's 2 main medical centers in the state, both of them in Indianapolis. Those are the only 2 big-time trauma centers in the state. So when somebody really gets hurt, they got to be airlifted from wherever they are to Indianapolis. One of those trauma centers, everybody seems to at least know about it, Methodist Hospital, treats mostly blunt force trauma. That's where the Indy drivers go when they have a wreck, all right? The other place is the county hospital called Wishard Memorial, and it's the home of the Knife and Gun Club, all right? So all the penetrating trauma tends to go there. As a resident, we spend an awful lot of time at Wishard Memorial. That's where I saw these guys. So here, my second patient, 29-year-old male. He's an assault victim, all right? The police that came in with him said, you know, he's a well-known member of the Indianapolis gang community. And he was assaulted, it was thought, as retaliation for something that he'd done. There was actually some witnesses to this attack. His girlfriend was with him and said that he got nailed in the back of the head with a club and also stabbed a couple of times. So he gets brought to Wishard, check him over, and he comes in stone cold unconscious. At the scene, he was unconscious. The EMTs noted a little bit of blood coming out of his ear, and that was confirmed when he was in the emergency room. Doc looked in his ear and saw a little hole in his eardrum. There's the source of the blood, end of story. So finally he wakes up in a less than happy condition, realizes he's not in too much trouble. They sew up his cuts and they eventually send him home. The one thing that was noted was he complained of hearing loss in that ear after he woke up, kind of got with it. He said, my hearing was fine before this happened, now I can't hear squat. People blamed it on the hole in the eardrum, which is a reasonable assumption. He was told eventually to come on into the ENT clinic, we'll check him over. So he does that. Finally comes in, this is about a month later, he had things to do, I guess, you know. But he finally comes on in, have us check him over because he still can't hear real well. Doesn't have any more bleeding, and when we looked in his ear looked a little bit like this. Eardrum looks a little weird, which I can understand. I mean, he had a hole in his eardrum, but he also has this line, which I can tell you ain't a normal finding in an eardrum. So we check his hearing. And we also managed to find a picture in his records that showed this big bruise behind his head. Also had a bruise in front of his ear, all right? It's thought that maybe he got nailed in front of the ear, but no one really thought much about this for some reason or another. So we finally were able to check his hearing, and he was found to have a real impressive conductive hearing loss, all right? 60 decibels. So basically, in real world terms, he can barely hear normal conversation out of that ear. That's not a normal finding when you have an eardrum like that. So we got a CT scan, which really highlights bone, and we saw this. If you take a look here, there's a little break here, goes all the way through here, right through this area, which is the middle ear, okay? His other ear, totally normal. So he had what's called a longitudinal temporal bone fracture. Basically, skull fracture that happens when you get nailed in the back of the head here. What it ended up doing to his hearing was separate his ossicles. He had an ossicular discontinuity. In other words, things got kind of ripped apart. The nice thing is, we can fix that. We were able to take him to the operating room, put in a little titanium prosthesis, and he started hearing great after that. Not perfect, all right? He still had a little bit of a hearing loss, about 20 decibels, but in real world terms, that's a success. We've given him almost normal hearing back from that. So now, we're getting into the real reason why I wanted to give this talk, okay? We've gone through the two parts of the ear. We did the ear canal with the cerumen impaction. We had the ossicle problem with the trauma. And now we got a lady with a real issue. 39-year-old lady who woke up again, can't hear out of her right ear, but she really can't hear. She'd been fighting an upper respiratory infection, had a little cold, maybe a little sinus problem, but really hadn't had much of an issue with her ears. She had some infections. She had one set of tubes as a kid, but that was about it. No other problems after that. So she came on in after having this loss for 2 days. We took a look at her ear, and it looked like this. That's a normal ear. Dead solid normal. Eardrum's nice and translucent. You can kind of see through it. There's structures behind it. No fluid, no pus, no blood, no nothing. So I did a tuning fork test on her. Tuning forks are great. Cheap, easy way to go ahead and sort of test hearing. And those tests suggested a real impressive sensorineural hearing loss in that ear. So we did a hearing test, and you don't need to be a rocket scientist to see there's a big difference there. Huge difference. Her left ear's up here with normal hearing, and down here, she's got really nothing. Lori did not put down her discrimination scores. That's basically how well your ear can discriminate between words. She didn't have any in that ear. She was literally hearing nothing. If you take a look here, these numbers represent how much sound we got to put into her ear to get a response. So her best hearing is at about 90 decibels, all right? So what is she able to hear? She might hear a lawnmower going off behind her, maybe. But she's definitely not going to hear her alarm clock in the morning. Normal conversation, that ear's out. She can't tell what's going on around her. So we got her diagnosed. Next thing we did was an MRI scan. Part of the workup. What's causing this? And dead solid normal. What you see here on the right side, this is her inner ear. That's the nerve that goes from the ear to the brain. Looks about the same as on the normal side. So there's nothing going on here. It's a totally normal brain. So she had what's a true sudden sensorineural hearing loss. Went to bed normal, woke up, no hearing. We treated her with 3 weeks of oral steroids, along with something like Valtrex, an antiviral medication. And after 3 weeks, she had an awful lot of improvement. She came back and she was at about 40 to 50 decibels. In other words, she could hear normal conversation. All right? We did give her a hearing aid now because she's still down. She uses that to good effect, and she's doing very well. But her hearing in that ear has still not come back up to where it was before. All right? So let's talk about this, because this is the kind of thing that always scares me. All right? Because remember, we take our hearing for granted a lot. People oftentimes will blow this off. So when it happens, you usually don't have much of a warning. You know, this lady had nothing at all. Woke up and boom, it's gone. Sometimes it's associated with an upper respiratory infection, but not always. And I've seen people that come in, they're in the prime of life and they feel fantastic. They don't have any medical problems, and they get this. They just wake up one day and their ear's gone. People always ask, well, geez, doc, what should I look for? Well, here's a couple of big red flags as a doctor. If you talk to somebody and you ask them the question, can you use that ear to talk on the phone? And they say no, that should send up a big red flag. There's a problem there. Because a phone is really a pretty good amplifier. All right? You can hear pretty nicely with that if you turn up the volume. If she can't hear, there's a big issue there. If somebody says, I hear stuff in my ear, it's buzzing, or maybe it's clicking, it sounds weird, but I can't understand what somebody's saying, it's Charlie Brown talk. Right? Again, big red flag. After I diagnose somebody with this and we treat them, they say, well, how did this happen? What caused it? And the true answer to that is, we don't know. All right? The only way to really tell is by taking somebody that's had this loss and taking their ear out of their head and looking at it under a microscope. Most people don't go for that idea. So we have some ideas as to how it happens, but why, we can't tell you for certain. The root cause of it, though, is inflammatory change. Something is making that ear get inflamed. It could be from infection. In other words, you get an inner ear infection, affects your cochlea, causes hearing loss. That infection causes inflammation around the cells that transduce sound. Body responds to that by sending in inflammatory cells to kind of fight the infection. Your body tends to go ahead and hurt your hearing. All right? Second thought could be decreased blood flow or sludging in the artery that goes from the carotid artery to your ear. I can tell you that's a real small artery. It's about 1 millimeter in diameter, and it's through solid bone. So it doesn't stretch much. All right? A little plug there has a lot of damage potential. Essentially, it's not really a stroke, but it's the same idea. You got decreased blood flow to part of your brain. When that happens, cells swell, they get inflamed, and boom, body comes back in and starts cleaning up the damage. So when you get that, you get the inflammation, part of the way to treat that is to treat the inflammation. However, always want to do an MRI scan. Not because I'm thinking you've had a stroke. You know, if somebody comes in, they're talking to me one-on-one, I can tell you they haven't really had a stroke. But I'm looking for this. What that is, it's called an acoustic neuroma. These are real small, benign tumors. They're not cancerous. They don't go anyplace. But it's the ever-popular, real small tumor in a really lousy spot. All right? Sometimes this is the first warning that a patient has this problem. If we can catch them small and we can get them into treatment, either surgical or with radiation, a lot of times we can save the hearing and get that back. But a larger tumor, when it has to be taken out, usually that kills off the hearing in that ear. All right? But we have saved a life. These things might be benign, but they do grow. And like I said, it's a real small tumor in a really lousy place. Now, the main problem with this is treatment's a little controversial. You know, if I had to take a look at the literature, most of what's out there are case reports. I do it this way. There aren't any big studies that say this is the way to treat it. All right? There just aren't. However, just about everybody would say that use of steroids and antiviral agents is a reasonable approach. Okay? Steroids, for all of their reputation of badness, in this case can be life-saving in a lot of ways. They help bring down the inflammation that causes the ultimate damage in the ear. Antivirals kill off any virus that's causing the infection to begin with, if it's an infection. Again, we just don't know. But if you don't know, treat it. I usually tell my patients, too, to use a baby aspirin a day. Not because it's going to make their blood real thin, but it helps decrease the risk of sludging. And certainly keeping them on that thereafter makes good sense. The question also asks, well, geez, when do I need to do something about this? Well, again, there's really no good consensus in the literature. All right? As a rule of thumb, the longer you wait, less likely it is that hearing can be restored. Okay? I've had folks come in a month after this happens to them. I treat them because that's what I got to do, but I don't have a whole lot of hope, in all honesty. And those people very rarely come back. How long you have, like I said, it's not certain. I've heard ranges from 3 days. If you don't initiate treatment within 3 days, there's a problem. Some people would say if they're hearing something in the ear, if they're hearing ringing or clicking or something, and you start treatment, you can get something back. Some people would say best way to treat it is put a tube in the ear, put steroids in the ear to get it right to the inner ear, and that'll help them out. But again, nothing here is set in stone. So I usually tell folks, probably the best thing to do, if you've had a sudden change in hearing and it hasn't changed in 3 days, get in to get seen. All right? Call your doctor, call the clinic, let us take a look at you, because that can make a huge difference. So what's the take-home message here? Real simple. If there's a change in hearing, don't blow it off. Please. It might be wax, it might be a little fluid in the ear, but then again, it might not. Second thought, and for folks with kids, you know, anybody that's out there, protect the hearing that you do have. All right? I can tell you as a physician, I'm going to see an awful lot of kids in the next 20 years that are using iPods and other things and not protecting their hearing, and they're going to have some loss. So if you use power tools, if you're wearing an iPod, use the right stuff, keep the volume down. Is there a test that says you're at risk for this? Not really. That's one of the reasons why when the hearing loss does happen, an MRI is part of the workup. These tumors aren't real common. There may be 3 in 100,000 people, but finding them is important because if they're not found down the pike, they could lead to death. Only if they're having real problems hearing. If there's a documented hearing loss, it's a good idea to follow them for a year or two, a couple years probably, just to make sure there's no major change. And then I always tell my patients, if you have noticed a change, make sure you call me. Get in so I can take a look at you. Maybe something I can help with. Good question, and again, not really certain. It's one of the reasons why I put people on aspirin afterwards. If it is due to sludging in the blood, that helps keep that risk down. Are they at risk? Could be. So when somebody has a sudden hearing loss and I treat them, I usually check them back in a year just to recheck the hearing and make sure things are still going okay. And then I tell them, if you have a change, if you notice anything, do not go to urgent care. Don't call your family doctor, just call me so we can check you over because we just don't know. And better to treat if there's a problem than to just kind of blow it off and risk losing that hearing. It depends. The first step to kind of figuring out would a hearing aid help you is to get a hearing test, all right? And that's going to tell me how much residual hearing you have in that ear. If your discrimination is very low in the ear, then a hearing aid may give you some understanding of what's going on, but in real world terms, if I amplify sound that you're having a hard time hearing, you're going to have amplified mush. There are other options. If you have normal hearing in one ear and poor hearing in the other, there are different types of hearing aids available. And again, that's probably a subject for another talk. But a straight hearing aid in that ear with very low discrimination probably is not the answer. So what else can be done? Certain forms of hearing aid, it's called, the technical term is cross hearing aid. What basically that is it's called contralateral routing of signal. You wear something on this side with a microphone on the other, and sound is taken from one to the other wirelessly. They help. A little hard to get used to. If hearing goes down significantly in either ear, to the point where it's really neither ear is aidable, then a cochlear implant is extremely helpful. Right? That's something that we did a fair number of in Indianapolis. I probably assisted in about 60 of those over the course of my training. And I can tell you that the changes in people are dramatic if you're going to qualify for an implant. They can talk on the phone, they can understand what's being said to them, they can listen to the TV, they can go to the movies. It can be a life-changing thing. I don't see that terribly often. Most of the time it seems to be just one. Okay? I've seen a couple of cases where it was both. All right? But those are definitely in the minority. Treatment's the same. And, now we're dealing with, if both ears are down, really rolling the dice to see how much you're going to get back. Again, good question, and the answer is we just don't know. All right? So once you have it, I'm a relatively conservative physician. I don't like to roll the dice with people's hearing. So I would say stay on aspirin the rest of your life. And if there is any change at all, scream loudly, get in, let me take a look. Because, and again, I think it just goes down to the fact that most people, most lay people, they're going to go ahead and say, that's nothing. It'll come back. I'll worry about it later. Because there just isn't the understanding. Thank you for coming out again. I appreciate it.